Hello, this is Chapter 11, Common Childhood Onset Genetic Disorders. I have broken this down into two parts. Part 1 is going to be the largest component, and Part 2 is only going to be about 10 minutes. Okay, we're going to talk about monogenic disorders. Monogenic disorders are disorders arising from a single chromosome mutation, and they are transmitted in an autosomal dominant, recessive, or a sex-linked pattern. So we're going to start with sickle cell disease, which is a monogenic disorder that is caused by a point mutation with a single nucleotide polymorphism in the gene for the beta chain of hemoglobin. All people with sickle cell disease have the same mutation, so there's not a lot of variability or variation there. It is autosomal recessive. Its incidence is 1 in 400 live births among African Americans, with a carrier status of 1 in 15 African Americans. It is much higher statistics in the equatorial regions. So here is a picture of the point mutation, okay, called a missense mutation. So it's a missense mutation in the beta hemoglobin gene that converts GAG codon into GTG, which encodes the amino acid valine rather than glutamic acid. So a missense mutation is a form of a point mutation that results in the formation of a different amino acid, and that causes the synthesis of a protein with an altered amino acid sequence during translation. And you can see on the picture here, the top identifies the formation of normal hemoglobin. You see in the 6th position, the amino acid sequence involves glutamic acid. And then down below, there's that mutation in the 6th position, and that results in an amino acid sequence that results in valine, which then is the abnormal, results in the abnormal sickling of cells, results in the formation of HbS hemoglobin. Okay, pathophysiology. The amino acid in the 6th position of the beta globulin protein is valine instead of glutamic acid, as we saw in that previous picture. And that mutation forms hemoglobin S instead of the normal adult hemoglobin. And red blood cells with high levels of that hemoglobin S form sickle shapes under low oxygen conditions. And that sickling of those cells block blood flow because they also clump together and they are stickier, and so they block the blood flow and cause ischemia distally to the point of the blockage. These red blood cells also have a shorter lifespan than cells with normal hemoglobin. Their lifespan is like I think 12 to 18 days instead of the normal 120-day lifespan of a red blood cell. So here's a comparison of a normal and a sickle cell, just kind of another visual of that. So you've got the normal sequence here, and then the hemoglobin molecules that result, okay, and the structure, the normal structure there in that 4 pattern. And then with the mutation, you get the resulting rope-like aggregates of that. And then visual at the bottom shows that normal hemoglobin shape with the smooth flow through the system, and then with that mutation you can see the sickling and the blocked flow and how they're all closer together and they're sticky and they block flow. Okay, here's another picture of a normal cell, a normal hemoglobin that can flow through smoothly, and then that's the sickling of the cells, the abnormal hemoglobin. You can see how they kind of block up and clump together and cause obvious damage with decreased perfusion to tissues. Okay, the disease and the carrier status is diagnosed by hemoglobin electrophoresis. Okay, and so what that means is that they will, the diagnosis is not done by genetic testing. It's diagnosed based on the large percentage of hemoglobin S seen on that blood test, that electrophoresis. So usually 80 to 90% of those with sickle cell disease will have, 80 to 90% of HbS will be in people who have the sickle cell disease, If they have sickle cell trait or they're carriers, it will be less than 40% of hemoglobin S present. So all those cells with just less than 40%, although they're less, they can still sickle, but the degree of tissue hypoxia required for that to happen is much less than that. The degree of the tissue hypoxia required is greater than that needed for the red blood cells with that 90% or more hemoglobin S, okay, to form sickled cells. So the carriers can still sickle, but it requires much greater amount of hypoxia to do so. And is characterized by pain during the sickling crisis episodes, as those tissues are being deprived of nutrients and oxygen. So there's intermittent poor perfusion and oxygenation of vital organs, especially the liver, heart, brain, spleen, kidney, bones, and retinas, eventually leading to organ ischemia, fibrosis, and death of the tissue. They have chronic anemia without iron deficiency because, again, these abnormal hemoglobins have a much shorter lifespan, and so about 16 to 20 days is what it is. And so they have anemia without iron deficiency. So if they get a blood transfusion, that needs to be, done cautiously because they can get iron overloaded with blood transfusions. They do have an increased risk for infections, and their life expectancy is significantly reduced. So hypoxic crisis triggers include change in environment, extremes of temperature, dehydration, high altitudes, infection, acidosis, venous stasis, strenuous exercise. So only moderate exercise is recommended, mild to moderate, and pregnancy and anesthesia can also trigger a hypoxic crisis. So management includes monitoring organ function, avoiding those conditions that we listed that cause hypoxia, treat infections aggressively and early, maintaining adequate hydration because dehydration is a trigger, promoting synthesis of fetal hemoglobin, or HbF, through the use of hydroxyurea. So the interesting component about that fetal hemoglobin is that fetal hemoglobin tolerates a low oxygen level without sickling. And so fetal hemoglobin is usually gone by the time an infant is 6 months old. Okay, so fetal hemoglobin is present in utero and at birth up to age 6 months, and then it is greatly decreased. However, some patients with sickle cell disease do continue to express up to 20% of fetal hemoglobin into adulthood, and that is helpful because it dilutes the percentage of hemoglobin S, which means there's a better tolerance of conditions that could cause sickling. And so in adults, we can create that hemoglobin F, and so the way to promote that higher amounts of that is through the use of hydroxyurea as a medication treatment. Other treatments include reducing oxidative stress with medication and DARI, supportive care, of course, and hematopoietic stem cell transplantation are options. So with these measures, sickle cell anemia is not curable, but it can certainly prolong complications through these measures. The disease advantage is that both the homozygous and the heterozygous states do create a resistance to the infectious disease malaria. So it is considered a genetic evolutionary disease because the sickling of those cells cannot, those parasites can't live inside those the sickle-shaped cells. So it is an evolutionary advantage. However, it only is an advantage in areas where malaria is high along the equator, close to the equatorial zones. So in this country, it is not an advantage to have sickle cell anemia, but it is an evolutionary trait, or is considered to be one. Okay, so here are some Punnett squares just identifying some outcomes of conception when you've got an affected and an unaffected, one affected parent and an unaffected parent. Okay, so just some, and if you've got a carrier state as well as a disease state individual, okay, and what the outcomes are. And these are important to identify because that will, that kind of helps us to counsel individuals who are concerned about the genetic possibilities in their offspring and what their risks are. Okay, so moving on to cystic fibrosis, another monogenic disorder caused by any of 1,700 known mutations in the large cystic fibrosis transmembrane conductance regulator gene. That's a mouthful, but I'll refer to it as CTFR. It is autosomal recessive. The incidence is 1 in 3,000 live births, and it occurs primarily among Caucasian Americans of Northern and Western European heritage. Carrier status is about 1 in 20 to 1 in 30 Caucasians. It occurs in other ethnicities much less frequently. And the CFTR gene is located on chromosome 7 on the long arm, the Q arm, at position 31. Okay, the CFTR protein promotes chloride and bicarbonate transport, and it influences other transport pathways. So the CFTR mutations disrupt these functions to varying degrees, and the major problem of that is a formation of thick, sticky mucus in the epithelial cells of the lungs, pancreas, liver, salivary glands, and testes, and that causes glandular atrophy and reduces organ function over time. Okay, so the CFTR dysfunction leads to the inability to secrete chloride ions, excessive amounts of sodium absorption and water retention, and that limits the ability to secrete chloride and absorb sodium in excessive amounts, limiting the use of water available to hydrate secretions. So the result is dry, sticky, thick mucus. Okay, here's a picture of that. So you've got on the left-hand side, you've got the normal CFTR channel, which allows the movement of chloride ions to the outside of the cell. And then over to the right, you've got a mutant channel, which does not move chloride ions, and that causes that sticky mucus to build up on the outside of the cell. Okay, so the disease status is diagnosed by the sweat chloride analysis. So genetic testing is only done to identify the carrier status or the prenatal diagnosis, and also in predicting potential disease severity. The diagnosis is done with the sweat chloride test. So individuals with cystic fibrosis will have a sweat chloride test result with high amounts of sodium chloride in their sweat, around 60 to 200 milliequivalents per liter, which is in big contrast to the normal value of 5 to 50 milliequivalents per liter in an unaffected individual. Lots of times moms will notice their babies are salty when they kiss them and then bring them in, and it's identified that they have cystic fibrosis. So here's some signs and symptoms, lung signs and symptoms. We all are familiar with the mucus plugs in the airways that reduce flow. That dry, sticky mucus, thick mucus also is a breeding ground for bacterial infections, which of course compounds the problem. So ultimately leading to respiratory failure and death. These individuals will ultimately at some point need a lung transplant. Pancreatic signs and symptoms include cyst formation. They have reduced exocrine and endocrine function. So the exocrine function is affected before the endocrine function is, because you have decrease in digestive enzymes. And that decrease in the digestive enzymes results in malnutrition, and which also leads to small stature because you need food to grow, and fatty diarrhea or steatorrhea. And there's also a decrease in fat-soluble vitamins as well. And diabetes mellitus occurs very late in the disease. So it's that exocrine function as far as the pancreas effect that's going to happen first. Miscellaneous signs and symptoms, according to your book, they have abnormal saliva, decreased liver function, and eventual liver failure because the liver and gallbladder are also damaged by the mucus deposits, and the liver will eventually fail as well. And then male infertility also occurs. Cystic fibrosis is extremely variable in disease severity and in organ involvement, although the expression of the clinical course is less variable within a given affected family. So there are a lot of degrees of severity amongst the entire population with cystic fibrosis, but it seems to be very specific symptoms within a given family. So management is chest physiotherapy, treating the infections to help get that mucus, help them clear that mucus up out of their lungs, treating infections aggressively and early, maintaining hydration, the use of pancreatic enzymes to help with the digestive issues that they have, supportive care, and as I mentioned, end stage would be lung transplantation. So there is a potential disease advantage to cystic fibrosis. Just from an evolutionary standpoint, according to your book, both the homozygous and the heterozygous states appear to give a resistance to cholera and typhus. Of course, there's no advantage in people affected in this area of the world where we don't really see cholera and typhus like we used to. We don't even see that in Northern and Western Europe like they used to. Years ago, these two. Okay, so here is, again, just some genetic possibilities of carriers. So you've got the father who is a carrier and the mom who's a carrier. And so the potential offspring of that is it's important to identify because they'll want to know what are their risks to their potential offspring. And then here down below at the bottom one, you have an unaffected father with a carrier mother. So there's 50% that there's no cystic fibrosis and 50% that there'll be a carrier of cystic fibrosis. As opposed to the above one where there are two that two are carriers, and then you've got a 25% chance that they will actually inherit cystic fibrosis expression. Okay, Duchenne muscular dystrophy is our last monogenic disorder that we're going to talk about. Well, nope, I take that back. No, we've got a couple others. So Duchenne's muscular dystrophy, monogenic disorder caused by any of a variety of mutations in the large allele of the large DMD gene, which codes for the protein dystrophin. Okay, dystrophin is a structural protein then that functions to maintain muscle integrity. So it is found in skeletal, cardiac, and smooth muscle cells. And in muscle cells, the dystrophin surrounds the muscle fiber membranes, and it helps to secure actually it does secure the contractile protein strands, especially actin, so they remain anchored and stable. So if you have too little dystrophin or non-functional dystrophin, with each muscle contraction, it loosens the actin and it gradually breaks down the muscle fibers and destroys the integrity of the individual muscle cells. And then the muscles lose fibers and fill with connective tissue and fat. Okay, it is X-linked recessive. Its incidence is 1 in 3,300 to 1 in 3,500. Sorry, I've got the comma in the wrong place and I need another 0. Occurs in males, but there are females that have been diagnosed with it, and we'll talk about that a little bit later. It occurs in all races and ethnicities, has a high spontaneous mutation rate. So there's a large percentage where their parents don't have it. So there's a spontaneous. So it can be familial or inherited, but there's also a high spontaneous mutation rate for this disorder. Okay, so pathophysiology, I've already touched on this a bit. We've talked about how the dystrophin protein maintains integrity of the muscle and cardiac muscle, and then how it gets broken down. Without dystrophin, the muscle gets broken down, okay, and then muscles become unstable and with every contraction break down. Okay, the disease status is initially diagnosed by a history of progressive muscle weakness and very high blood levels of creatine kinase. Okay, high blood levels of creatine kinase and also myoglobin occur. Both are usually inside the cell, but when that cell is damaged, those components leak out. And so the amount of creatine kinase and myoglobin decreases as the child ages because there's not as much muscle left to destroy. And muscle biopsy confirms the diagnosis. Okay, and then the DMD direct sequencing genetic testing is useful again for carrier status and for prenatal diagnosis. The muscle weakness first noted in the neck and hip girdle muscles of young boys because males are mostly affected, but generally around age 2 to 5 you'll start seeing signs of severe, like some developmental delay in the walking and such. Problems with walking and sitting upright become apparent between the ages of 2 and 5 years. The lung and pancreas function is affected most often, and life expectancy is significantly reduced, typically in late adolescence, early adulthood. However, again, females can have it, and if in the carrier state, they can express it because recall from chapter 4, you've got 2 X's, 1 X becomes inactivated, and that's a completely random process, and in which cells, which X is going to be inactivated. And so you can have a female, and if that unaffected X is inactivated, then you've got the affected carrier X that then becomes apparent. And so you can have a female with Duchenne muscular dystrophy, but to probably a much lesser extent. I took care of a lady in a care facility, and this was her diagnosis, and she was much older than the typical age. She was elderly. Okay. Okay, so more signs and symptoms. Inability to walk by age 10, dilated cardiomyopathy, and heart failure. Okay, so the heart effects are really pronounced here because the heart needs at least 80% of their muscle cells to be fully functional to work. But skeletal muscle only needs 50% of their cells to be fully functional. Okay, so those cardiac effects are going to be prominent, and there will be then ultimately leading to heart failure. There is a progressive reduction in cognitive ability. It's unknown why, but they think that perhaps some dystrophin is required in the brain. They have frequent episodes of pneumonia, and then, as I've mentioned, death usually occurs in early adulthood. There is no cure. Steroid therapy is used to help slow the rate of muscle cell degeneration, which is interesting because we know steroids break down muscle, but in Duchenne's muscular dystrophy, that anti-inflammatory effect of the steroids actually help to slow the process. But it's of degeneration, but it's short term. It's only used like for about 2 years, and it helps to prolong the destruction of those cells. And so I added a Cochrane Review article on the use of steroids for the treatment of Duchenne muscular dystrophy here, if you're interested in clicking on that. Weight management is needed to prolong mobility. However, the challenge is the use of the steroids also causes weight gain. So a lot of education here and follow-up. Mild to moderate exercise is recommended. Strenuous exercise is not, because that's going to cause further breakdown of muscle. And then, of course, cardiac and respiratory supportive care. Okay, so here are some Punnett squares on potential outcome of conception, okay, depending on the disease and or carrier state of the parents. Okay, so just review that. Those are things that parents want to know. What are my risks and potentials? So we are moving on to classic hemophilia, again, another monogenic disorder caused by a variety of mutations in the large allele of the large F8 gene, which codes for factor VIII, clotting factor. Mutation may be unique to a family. It is a sex-linked, X-linked recessive disorder. Okay, you see the incidence here. It occurs in all races and ethnicities, and it also has a high spontaneous mutation rate. Okay, so here's a pattern of inheritance. We've got a father without hemophilia and a mother who is a carrier. Okay, and so then you see the potential outcomes of that union. Here's a hemophilia karyotype. Okay, and then you've got, again, the karyotype of the parents. You've got, on the left, you've got a set of parents and the potential offspring. On the right, you've got a set of parents where the father actually has hemophilia and the mother is unaffected, and their potential offspring. So activated factor VIII works with other activated clotting factors and von Willebrand factor to form a complex known as prothrombin activator. And that complex converts prothrombin to thrombin, and thrombin converts fibrinogen molecules into fibrin strands, and that forms the base frame for a blood clot. Okay. The lack of or insufficient factor VIII prevents that thrombin activation, fibrin formation, and blood clotting. So here's a picture of it. Okay, on the left, okay, so you've got an injury. On the left, you've got a normal response, and then on the right, you've got what is occurring if they have hemophilia A, which is classic hemophilia. Hemophilia B is what was referred to as Christmas disease. Just FYI there. So classic hemophilia, bruising and excessive bleeding in response to any trauma during infancy. The petechiae do not form in areas of trauma. There is extensive joint damage in weight-bearing joints, hips, ankles, and knees because of the stress of those areas, the weight-bearing stress. Diagnosis is based on a history of excessive bruising and bleeding. Okay, clotting studies show normal prothrombin time and prolonged partial thromboplastin time. Blood levels of factor VIII are low or absent. The F8 gene sequencing can be done to determine the family's specific mutation. And here down below here, I've got a picture of a guy who has that involvement in the knee with the hemophilia. Okay, because of the weight-bearing joint. They bleed into the joints, and then that also causes further destruction of the joints. So female carriers have lower than normal factor VIII levels and bruise and bleed easily. Extensive joint damage in weight-bearing joints, as I've mentioned. A disease variability is based on levels of the factor VIII. Okay, so there's varying degrees there. Life expectancy with factor VIII therapy is 65 years. Management includes regular infusions of factor VIII. A liver transplantation can result in a cure, but is rarely performed for this disorder for obvious reasons. They have bleeding risk. Okay, so pretty scary to do surgery on someone with hemophilia. Okay, von Willebrand disease, or VWD. Another monogenic disorder caused by a mutation in the von Willebrand factor gene. The most common form has autosomal dominant transmission with reduced penetrance and variable expressivity. Okay, so there are 3 types of von Willebrand disease. The first 2 is autosomal dominant, and 80% is type 1, are type 1. And type 3 is of von Willebrand disease is an autosomal recessive, and that's the most severe form. These all occur in all races and ethnicities, and there is a high spontaneous mutation rate. Okay, so what do we mean by reduced penetrance? Okay, so remember the proportion of people with a genetic change who exhibit signs and symptoms of the genetic disorder. So if some people with mutation do not develop features of the disorder, the condition is said to have reduced or incomplete penetrance. Okay, the von Willebrand factor is produced by vascular endothelial cells and works with factor VIII as a glue to hold the parts of the prothrombin activator complex together. Okay, it also activates platelets, and as I've mentioned, there are three main types of von Willebrand disease. Type 1, most common, about 80% of people have type 1. Type 2 produces normal amounts of abnormal von Willebrand factor. Okay, and type 3 is autosomal recessive. That AR is autosomal recessive inheritance. It's most rare and it's the most severe form. So oftentimes types 1 and 2 go underdiagnosed. Again, lower than normal von Willebrand factor levels that are variable. Frequent nosebleeds without trauma. So that's interesting because lots of people say, oh, nosebleeds run in my family, and they just kind of take that to be, you know, that's just my family. We all get nosebleeds, and it eventually stops, and it's no big deal. But if you have an individual who has frequent nosebleeds, and then when they get to puberty, a female, and they have heavy menses, and then also, you know, with babies, and they have a high incidence of postpartum hemorrhage. You've got all that in their family history. That typically is what is going to lead a doctor to start identifying and seeing if they have a clotting disorder. So a lot don't get diagnosed until they are into adulthood. And interestingly enough, people with type O blood tend to have that, more of an expression of that. That's in your book on page 224. Remember the page number. I found that to be very interesting, that association with the type O blood. Oop. Okay, sorry, I didn't talk about this yet. So the F8 gene sequencing can be done to determine the family-specific mutation. Okay, we mentioned that. Female carriers have lower than normal factor VII levels and bruise and bleed easily. Okay, so that, again, that comes from your book. I'm kind of wondering if that factor VII is a typo, and that should be factor VIII. But factor VII certainly is another clotting component. But that is stated in your book. There is extensive joint damage in weight-bearing joints, the hips, ankles, and knees. And then, as we mentioned, disease variability is based on what kind of levels of factor VIII they have, okay, because they work together with von Willebrand. And then life expectancy with factor VIII therapy is 65 years. So desmopressin nasal spray or injection is used for type 1, and that, again, that's most of the cases, and possibly type 2. So that is that's interesting, because what that does is that increases von Willebrand factor, and it also increases factor VIII. And so it releases, desmopressin helps to release the preformed factors from cellular storage sites. So it has a rapid effect, but type 3 doesn't respond to it. So if you have type 3 von Willebrand disease, they need infusions of plasma with concentrated levels of von Willebrand factor. And then again, liver transplantation, but rarely done because of the obvious bleeding risk. Okay, moving on to achondroplasia. Achondroplasia literally means without cartilage. Okay, another monogenic disorder of human short-limb dwarfism that occurs as a result of a mutation in the gene that codes for the fibroblast growth factor receptor 3, or FGFR3. It is autosomal dominant. Okay, you see the incidence here. It occurs in all races and ethnicities. It also has a high spontaneous mutation rate, up to 85%, and about 80%, 80 to 85% of individuals do not have a parent with achondroplasia. So that just gives you an idea of that high rate of spontaneous mutation. The homozygous state appears lethal to the embryo. Okay, so here is just an inheritance pattern of achondroplasia showing the likelihood of the offspring depending on the parental genotype. Okay, so the protein product of the FGFR is involved in the development and maintenance of bone, also brain. but mainly bone tissue. It is a receptor that limits the formation of bone from cartilage, especially in the long bones. So these individuals have short humerus and short femur, and then they have that excess skin that causes the creases. They have those creases in their arms that I'm going to show you on a picture coming up. And the mutated protein is an excessively active receptor for fibroblast growth factor, and that shortens the long bone growth during embryonic and fetal life. And 2-point mutations cause 99% of this disorder. So the intellectual potential is the same as the general population. They have a slightly larger head size with some frontal bossing. Disproportionately short extremities. I mentioned that humerus is shortened and so is the femur. And the creased skin, because you've got the skin doesn't shorten, the bone shortens. Okay, and then the short neck with abnormal junction to the head. So with all that, sleep apnea is a common problem in these individuals. And there is a high incidence of sudden infant death syndrome as well. So here's a picture of a baby, and then a picture of an older individual, child to, looks like a child. I didn't get the age on this individual when I got the picture, but you can see the short humerus, you can see the creases in the skin on that upper arm area, okay, and then those very definitive features there. Okay, here's a comparison of physical appearance of adult males. You've got the typical male, 6 feet. You've got a male with growth hormone deficiency, 4'3". You see here that he's very proportionate. Even though he's shorter, he does not have, I mean, his limbs are in proportion to the rest of his body. And then you've got a male with achondroplasia dwarfism, which has very specific structural features there, and only as tall as 4 feet roughly. Okay, so there will be delayed motor development. We've talked about the short stature, the lordosis, or the swaying of that lower back. Teeth tend to be crowded with a poor bite. They might have hydrocephaly, but that's not present in all of the individuals with achondroplasia. So management would be weight control. Growth hormone therapy can be given, but it's minimally effective because this is not a growth hormone deficiency issue. This is a genetic issue, a chromosome issue, and so growth hormone may help them gain a little bit of height, but it's not going to have very dramatic results, not like it does in an individual who has a true growth hormone deficiency. There is bone lengthening surgery available. You can see here this picture, she's got an external fixation device as a result of that. And then, of course, sleep apnea therapy. Okay, and that concludes part 1. Thank you.